Before I start, I have no financial disclosures for this talk, although I do have funding for research from industry with the ones that are listed here, Franz Viral Therapeutics and Antech Medical for some research projects that we are running here at OHSU. So for the next about 45 minutes, I'd like to talk to you about total neoadjuvant therapy. I think it's important to look at the landmark clinical trials where we've been able to look at different protocols and the reason why we have switched some of the sequences of how we perform therapy for patients and when we do chemoradiation, when we do chemotherapy, and when we do surgery as well. And so this is a very exciting time for us because I think before this time, probably around the early 2000s, that's when everybody was looking at chemoradiation before as neoadjuvant rectal cancer. And then now, all of a sudden, 15 to 20 years later, then we're switching the protocols again. So there's a little bit of a lag time, I would say, between how we approach rectal cancer. Along with this, we're going to look at the oncologic outcomes, more importantly, the reason why total neoadjuvant therapy is basically taking over in the United States and in other countries. And part of that is looking at complete clinical response and the watch and wait protocol. Basically, we'll be looking at the benefits of having TNT, but then also I think there's a cautionary note as well that I'm going to talk about at the end. So if you look at the traditional treatment for locally advanced rectal cancer, generally what we do is patients will receive neoadjuvant therapy, so that's before surgery. So they receive radiation and they receive a chemosensitizing agent, so generally full 5-FU based therapy. And then they have surgery, and then that's followed by adjuvant therapy, so after surgery, and then they receive chemotherapy. So the goal of receiving chemoradiation therapy is that you're taking these really big, bulky tumors that are sometimes node positive, and basically you're shooting radiation at them to shrink them so that we're able to do an adequate surgical resection known as the TME to achieve a good oncologic outcome. And then after surgery, you get chemotherapy because the point is to try to decrease the possibility of the cancer having distant metastasis in the future. So if you look at this study published by Bosset, they looked at patients who had either preoperative radiation versus preoperative chemoradiation versus preoperative radiation followed by postoperative chemotherapy. And so one of the things that I wanted to point out is that in this cohort of 506 patients, not many people made it to postoperative chemotherapy. And so you see here only 26.9% did not make it to therapy. And part of the reason why was because when you do chemotherapy after surgery, then they can have complications that exist after surgery, and then that delays them to getting to chemotherapy. And so they don't get the complete, what we think is as the complete treatment for rectal cancer. And so this is looking at some studies and looking at the studies where patients also received adjuvant chemotherapy. And so you can see the regimens listed here, but basically looking at compliance for the patients that were able to get to chemotherapy after surgery, so adjuvant chemotherapy, it was pretty abysmal. So most of the studies, only 50% of patients made it to adjuvant chemotherapy. And as you saw on the last slide, a good contribution to this was because patients were having postoperative complications that caused a delay for them to get to adjuvant chemotherapy. And so they weren't able to complete their rectal cancer treatment. So this is a study looking at postoperative complications. And so we already know that basically the goal is to get to chemotherapy, usually within the first 6 to 8 weeks after surgery. And so even when you look at patients who receive chemotherapy that haven't had a complication, then going beyond 8 weeks, their survival drops. And if you look at patients who have postoperative complications who receive chemotherapy in a delayed fashion, their survival drops even further. And you can see that's pretty significant here as well. It drops by almost half if you look at the charts here. So, so one of our surgeons who's at Memorial Sloan Kettering, I think is basically an absolute genius, Dr. Garcia Aguilar, thought, well, if patients aren't making it to their adjuvant chemotherapy, why not give them the chemoradiation first, give them a break, and then let's give them chemotherapy before we even get to surgery. And so there were 4 treatment groups in his study. And so basically, he looked at the traditional patients getting chemoradiation therapy first, and then followed by surgical resection or TME. And then group 2 was receiving chemoradiation, and then 2 cycles of FOLFOX, and then having a surgical resection. Group 3 was having 4 cycles of FOLFOX after chemoradiation, and then group 4 was receiving 6 cycles of FOLFOX, and then having a TME. And so what's really interesting is they looked at after surgical resection, what the pathologic complete response, and they actually found that it was actually better. And so it went from traditionally what we generally see is having about a 20% pathologic complete response in our specimens after traditional chemoradiation to having a 38% pathologic complete response after receiving chemotherapy before having surgical resection. So the next protocol that was tried was looking at whether having long course versus short course radiation made a difference. And so this is a RAPIDO trial. So the goal was also to get to surgery as well. And so basically, the 2 groups that were examined were patients who received short course radiation therapy, so 5x5, followed by either having CAPOX or FOLFOX, and then having a TME, versus having capecitabine-based chemoradiation, and this was long course with TME, and then 8 cycles of CAPOX. And so, interestingly, they found that having chemotherapy before you have surgery with short course also increased your chance of getting a pathologic complete response as well. If you look at the Prestige trial, then they randomized standard chemoradiation therapy followed by TME, and then adjuvant chemotherapy to the experimental group, which received systemic chemo prior to chemoradiation therapy followed by TME, and then received adjuvant chemotherapy as well. And so, again, I think basically it's showing that when they're receiving some type of chemotherapy before, then they're having better pathologic complete responses. And it shows because these are patients that are not having complications because they don't have surgery yet, and so they're receiving chemotherapy before they get to surgery itself. And so just to back up, just to go over some nomenclature for total neoadjuvant approaches. When you received chemoradiation therapy first, and then follow that by chemotherapy, and then proceed to surgery, then that is called consolidation chemotherapy. So that you get that after you get chemoradiation. And so basically what you find in general is that when you receive chemoradiation therapy, then you're actually decreasing the tumor size, so you're increasing the tumor response. And then if you receive chemotherapy before you proceed on to chemoradiation, we actually call that induction chemotherapy. And so generally what we do is we look at the staging, and then we look at if there's any evidence of micrometastases, if there's a concern, so EMVI, basically if there is a concern for that, then they get chemotherapy before. And then in addition to that, sometimes for treatment compliance, and they'll start chemotherapy before they start chemoradiation itself. So this is a German trial, the CAO-ARO-AIO 12 trial that evaluated the pathologic complete response in patients who underwent induction chemotherapy, followed by chemoradiation and then surgery, versus chemoradiation followed by consolidation chemotherapy, and then surgery. And so basically the goal of the study was to look to see whether induction chemo was potentially better or consolidation chemo was better. And so they found that if you received chemoradiation first, so you're basically shrinking that tumor, followed by consolidation chemotherapy, then you actually had a better pathologic complete response. So I believe that Dr. Herzig had presented the Oprah trial a couple of months ago. So I'm just gonna briefly touch base on this because I know he talked about this quite a bit. But basically, these were patients that were evaluated after receiving chemoradiation therapy first, followed by consolidation chemotherapy, versus receiving induction chemotherapy, followed by chemoradiation therapy. And then if they ended up having a complete clinical response, then they were enrolled in a watch and wait protocol. And so they evaluated their 3-year disease-free survival. And basically, it was about the same that you can see here. But interestingly, when you look at consolidation chemotherapy versus induction chemotherapy, then their 3-year TMA survival was, having organ preservation was actually higher in the patients that received consolidation chemo. So getting chemoradiation first, and then consolidation chemo next. So as you may or may not know, the Prospect trial was recently published. And so I couldn't finish off these trials without talking about the Prospect trial. So basically what they thought was, well, if people are giving and focusing on chemotherapy, then why not see if radiation is necessary? Because a lot of these patients who are receiving chemotherapy are having complete clinical responses. And so I also just wanted to point out that their patient population is actually pretty narrow. So they looked at T2 node positive cancers, T3 node negative cancers, T3 node positive cancers, but then their exclusion criteria also included T4 tumors, having 4 or more pelvic lymph nodes with a short axis larger than 10 millimeters, tumor visible within 3 millimeters of the radial margin. And so they weren't looking at what we think, basically they weren't including all locally advanced rectal cancers, which I found pretty interesting. And so basically they found that chemotherapy was non-inferior to going through the traditional route of chemoradiation therapy, and their local recurrence rates were basically the same. But I would just keep in mind that they excluded quite a lot of what we also think of as locally advanced rectal cancers. And so what are the benefits of total neoadjuvant therapy? So what we've seen thus far is that basically patients can get their chemotherapy, and complete it prior to having surgery. So you take out the factor of the patient having postoperative complications and delaying them getting to chemo and potentially not even having chemotherapy or adjuvant chemotherapy. We've seen that with total neoadjuvant therapy, patients do have a higher pathologic complete response rate and better disease-free survival. And this may even increase patient compliance, because when we tell a patient, well, potentially you could avoid surgery by having total neoadjuvant therapy, then they're more willing to do it, especially with the implications that come with having surgery itself. And so, as we all know, there are always complications that happen with surgery. And so, for example, we know that these rectal cancers are very morbid. And so here's an anastomosis with a leak point. And basically the result of the abscess, and these are challenging to treat. Patients suffer quite a bit. And it's really challenging to take down the anastomosis and redo another anastomosis again in the future when they have these complications. As you can see, there's many different organs that are packed very tightly in the pelvis, both the male and the female pelvis. And there are a lot of different nerves in the pelvis that control the functional status of the patient. And so generally when we do a low anterior resection with a very low colorectal anastomosis, then patients will get low anterior resection. So as you know, they will describe that they have fecal urgency. A lot of times they're rushing to the bathroom, they have diarrhea, they have very small bowel movements and very frequent bowel movements. And this happens to almost 90% of patients that undergo a resection for really low rectal cancer. And in general, they have a poorer quality of life and just obviously not very satisfying for them at all. So we talked about the fecal urgency, incontinence. They also have issues with sexual dysfunction as well, and urinary dysfunction. In addition, when we do these really low anastomoses, then they're diverted with an ileostomy. Sometimes they do get a permanent colostomy. And I would like to think that all of my ileostomies or colostomies look like this, but sometimes they don't look that great. And here's another picture. So here's a diverting ileostomy, and you can see basically some herniation for the patient. So as these surgeries can be very morbid for the patients and really affect their quality of life. And so if you look at patients that undergo watch and wait protocol after chemoradiation, so just to take a step back, this is actually a study looking at quality of life for patients that underwent watch and wait protocol after the traditional neoadjuvant chemoradiation therapy. And so they looked at their long-term quality of life. So they did multiple questionnaires, as you can see down below, looking at function and also quality of life. And so what they found is that in this cohort of patients, after about 24 months, these patients reported a 25% rate of bowel dysfunction, which is significantly better than what we see with low anterior resection. So I would note that even with chemoradiation and obviously any type of intervention, you're always going to have some type of sequelae. And so with following patients over time for their sexual dysfunction, it did decrease over time, but the numbers are a lot lower compared to if you were to have a very low colorectal anastomosis. And then from a quality of life standpoint, they definitely found that patients who underwent a TME had a significantly worse quality of life compared to patients who underwent watch and wait protocol. And so I think there's some important considerations to think about when you're approaching total neoadjuvant therapy. And so I just went through quite a lot of different protocols and clinical trials that we've had. And the thing is, the question is, which type of regimen is best for the patient? And the other issue too is we know from Dr. Habergama, who is the queen of watch and wait, that even with traditional chemoradiation therapy prior to having TME, then we would find a complete pathologic response rate of about 20%, although in her series, she did say her series of patients, I believe, was about 40%. But either way, we do know that there is a group of patients that after traditional chemoradiation therapy will achieve a complete clinical response. And so if you're treating them with induction chemotherapy or consolidation chemotherapy, is that extra chemotherapy that you're giving them? Because as you know, there's side effects to the chemotherapy themselves, such as nausea, vomiting, diarrhea, neuropathy. And so who are these people that we're overtreating that would otherwise respond to chemoradiation? And I have to say, I'm not really sure we know who these people are, how to parcel them out. And the other issue too is that following these patients and surveilling them from a watch and wait standpoint is extremely time consuming and takes a lot of effort. And so if you look at the NCCN guidelines, the protocol for watch and wait is doing a history and physical exam every 3 to 6 months for 2 years, and then every 6 months for 5 years, and drawing labs as well. But the really labor-intensive part is following them with flexible sigmoidoscopy every 3 to 4 months for 2 years, and then every 6 months for 5 years, and then getting an MRI every 6 months for at least 3 years, as well as following them with CT scan. And I have to say, it is pretty challenging to get a patient to come back every 3 months. And I have to say that 3 months turns into 6 months. And so it's pretty challenging for a patient to be compliant when you're trying to do watch and wait approach for them. The other issue is accuracy of the modalities that we use to watch and wait. And so as you can see here in pictures A and B, if you look at the endoscopy, you can see the tumor itself. And then on MRI, you can see the tumor that's in the white, that's equivalent to what's seen on endoscopy. And then when you have a complete response, then obviously you have shrinkage to nothing of the tumor on endoscopy. And then basically that hyper-intense focus that you see of the tumor itself becomes hypo-intense. And then generally you're able to see the different layers of the rectal wall itself. And so for accuracy, I don't think we're completely there yet. And so basically the study was looking at the accuracy of MRI and different imaging modalities for rectal cancer. And so generally we use MRI, and it's only 75% accurate, 95% sensitive, and 31% specific. And so while MRI might be useful in ruling out complete response, it may not be as good at confirming it. From an endoscopy standpoint, the pitfalls of looking at this are that you're only able to see the luminal surface of the where the tumor used to be located. And so when you're looking for a complete clinical response, and you're looking for absence of the tumor, the mass, and it has to be flat, there's a white scar, not really any telangiectasias, and then potentially a complete response, then you'll see a small flat ulcer with smooth edges, no signs of residual tissue. And so I generally will tell my patients that basically all of the tests that they have for surveillance have to be perfect. So when I do a digital rectal exam, then I can't feel anything that's concerning from a tumor standpoint. And the MRI has to show a complete response, and then on flexible sigmoidoscopy, then there can't be any evidence of tumor. And so I've had patients that will come in and say, well, my CT scan and my MRI were negative, but then when I scope them, then I see a tumor. And so all three of them have to be perfect when you're doing your surveillance with the different modalities. So one final thought that I will say is we don't really know what the perfect protocol is for total neoadjuvant therapy. There are multiple different trials and protocols that exist. The one that we use here at OHSU is generally we'll use long course chemoradiation therapy. If the goal is to achieve a complete clinical response, then they'll receive chemoradiation therapy to shrink that bulky tumor down, and then consolidation chemo, and then followed by restaging. And then if there's any evidence of micrometastases, so any extra mural invasion, vascular invasion, then they'll receive induction chemotherapy first, followed by chemoradiation, and then they'll reassess to see if there's any type of response, and then possible surgery. And so that's our protocol at OHSU. I think that we need to identify other different biomarkers in the future, and I think those remain to be seen. I would throw out there, I think that ctDNA is going to be used a lot more in the future. Obviously, it's very preliminary, and we only have data from advanced stage 2 cancers with ctDNA, but that's my personal thought. So with that being said, I wanted to thank you for giving this talk, and I'm happy to answer any questions. Thank you.
Thank you very much. Can I ask from the non-GI surgeon point of view? Number one, nowadays with a lot of genetic therapy in place, I mean gene abnormality, and then we kind of early prevention. Like for breast cancer, we have BRCA1 gene. And then once we discover, we kind of like remove the breast, ovary, and uterus. From what we heard from the other OHSU expert talk with us earlier. So for rectal cancer, do we have that kind of prevention nowadays, or is there a trend or anything like that?
Well, I think, so just to make sure that I understand what you're saying correctly, you're asking if we are finding a potential biomarker and then doing something prophylactically to prevent the rectal cancer? Is that the question?
Not the actual biomarker. I'm talking the gene itself, the abnormal gene that once it's detected and there is a known gene to develop this kind of thing in the future. So we kind of like do some kind of early prevention. Is there any trend like the breast cancer?
I mean, I don't think that I think the only genes that we know of are pretty common that have been around for a while. So, for example, testing for Lynch or FAP, but I'm not aware of any other newer genetic markers that we look at that would potentially predict a rectal cancer in the future.
Thank you. Doctor, the doctor attend any question from your side for Dr. Fang? Ajahn Ton, any question from you?
Thank you, Ajahn Vanapa. Thank you for nice talk. I would like to ask you two questions. The first, the duration for surgery after TNT. What is the suggestion for waiting time before surgery? And another one, I would like to get your opinion about neoadjuvant treatment for rectal cancer in the role of immunotherapy. Please.
Those are great questions. Thank you. So generally what we do is if you received chemoradiation therapy first, followed by consolidation chemotherapy, then we'll wait a month just so that they clear their chemo before we perform TME. And then if they receive induction chemotherapy followed by chemoradiation therapy, then we'll wait generally about 6 weeks before we go in, 6 to 8 weeks before we go in to do TME. I will say that it is a little bit different with short course radiation therapy. So we do long course here at OHSU. We actually did short course radiation therapy when I used to practice in Baltimore at Hopkins. And so there's variation between what different institutions do. And so with short course radiation therapy, we would actually wait about 1 to 2 weeks and then operate on them, which is pretty challenging, I have to say, because there's always this huge backlog of patients, right, waiting for surgery. So to try to get them on within a week or two after we gave them short course therapy was pretty challenging. So I would say realistically with short course radiation, we were getting them on the schedule between 1 and 4 weeks when I was practicing in Baltimore. As for immunotherapy, you're probably aware of the fact that that is also a really huge topic here. And you probably saw that study that came out of Memorial where they looked at 12 patients who were MSI high, who received immunotherapy, and every single patient had a complete response, which is really amazing. So I actually have a very young patient who's 36 years old, who's MSI high, and his medical oncologist locally decided to give him immunotherapy. So I'm actually following him now, and he's like literally almost to a complete clinical response, which is pretty amazing. So those are great questions. Thank you.
Thank you very much. That's all. Yes.
Thank you. How about Korat? Any question from you for Dr. Fan? Okay, how about พัทยาคะสมิติเวช Okay, อาจารย์ Art, I'm sure you have a question.
Thank you. Right. No, not a question. Not
very clear, right?
Question. Right. Hello, Dr. Fang. Thank you for such and Dr. Lu and Liana and Leah and everybody. Thank you for such an outstanding, presentation. And I think we are now up to watch and wait protocol formally, because as we were listening, we've been listening to Professor Angelita Bahagama for decades on this, and then finally we found a match protocol that everybody would agree with to proceed with this protocol and approach. So my question would be a very simple one. I'm not sure for your routine, practice on locally advanced rectal cancer patient who you think would be eligible to TNT. I'm sure you guys are doing all this with MDT approach as well. And I'm not sure which one between the consolidation and induction TNT would be more popular, and which one between of these two choices you have any way to select which protocol would be appropriate to which group of the patient? Thank you.
Right. So generally, what I understand here at OHSU is if you have a really large, bulky cancer and you're trying to get them down to a complete clinical response, then you start with chemoradiation followed by consolidation chemotherapy. But if you're worried because there might be evidence of micrometastasis, so if they have EMVI, then you start with induction chemotherapy because you're worried about potential micrometastases that might result in them having potential distant metastases in the future. So then you would consider induction chemo first, and then you would follow that by chemoradiation. So that's my general understanding. Dr. Liu, I haven't been here as long as, not very long, so any other comments about what the protocol is here?
Agree with her description. I would say that you get more downstaging and a higher complete pathologic response or complete clinical response with chemoradiation first. It's patients that we, like she said, that if you have extramural vascular invasion or venous invasion, it's a high correlation with metastatic disease, and we want to get them chemotherapy sooner. So it seems like all the studies consistently show that chemotherapy is what really decreases mortality. So if we think that they have a lot of metastatic disease up front, then they'll start with chemo induction. But we tend to lean toward long course chemoradiation first, followed by chemotherapy. We also think that the longer you spend away from radiation, the better the response. So having it upfront burst gives you way more time away from the radiation to get a complete response.
Ajahn At, any question from you? More?
Not really. I'm just looking for, like we have been reviewing, I think, high quality and very standard randomized control trial on TNT so far, and the results are pretty much outstanding, both to the local control and then the systemic control. Compliance is higher, less toxicity, so yeah, very exciting to look forward to the application clinically for real. Thank you.
I
Dr. Art, can you hear me? Oh,
Yes.
hey, Art. It's Liana. So it just was presented in ASCO 2023, literally a week ago, about the OPERA trial, which is the watch and wait, the 5-year outcomes. And it clearly shows that the chemoradiation first with consolidation chemo led to a higher pathologic complete response than induction chemo to chemoradiation with very good oncologic outcomes. So our preference, as Dr. Fang mentioned, being chemoradiation first and followed with chemotherapy, it just follows that protocol, the OPERA trial, because we were a site of that trial as well. Now, very nicely also Dr. Fang and Dr. Liu kind of, alluded that when we think they have EMVI on MRI, when we think that there is a high risk for metastatic disease that we cannot yet see on CT imaging, then we're finding out that starting with chemotherapy is because we are concerned that it will be just a matter of time before we see metastases. So I think the trial now, OPERA, is going to be at JCO published, I think, coming up. So I think it kind of consolidates or confirms the protocol we have followed so far.
Right. Thank you. Thank Liana. Because I would agree absolutely with you, because among those results from randomized control trial, OPERA trial seemed to be the most impressive, at least to me, and then the outcomes is just outstanding. And the only thing that we have discussed from the last meeting, that the only pain is the follow-up for watch and wait, like MRI every 6 months or so. So yeah, I think, and thank you for that updates, and that's really give me a very good information as well, and that's a very nice study from Sloan. Thank you.
Right now, what are we doing at our BDMS site for this? Are we doing TNT or what else? อาจารย์คะช่วยแชร์หน่อยได้ไหมคะตอนนี้เราใช้อะไรกันแน่
I'm not sure. For my own practice, I think we are more toward TNT. Of course, we do have our own multidisciplinary team approach of the specialists, and I'm sure the medical oncologist and radiation oncologist and everybody in the team would agree with TNT, and we are very excited on updating the data, and we are very excited to have, at the end of the day after the surgery, patients would be complete pathologic response. Of course, like TNT is much better. TNT followed by TMV is much better approach in our country, at least in my practice and in BDMS. And but as I mentioned earlier as well from the last meeting, that watch and wait would still be something challenging. Thank you.
This is a side note. If I were happen to be the patient, I can still choose watch and wait, right? I mean, it seems to me that it can be either way. Am I understanding correctly? Sorry.
Yeah, certainly, because it would be, of course, like depending upon the motivation of the patients as well, and patients' compliance as to be willing to come for follow-up, because the follow-up is the key. Even though it seems like 60% complete clinical response from Angelita and Oprah trial results. However, we have to be cautious that about a fourth of these 60% would be recurred. Luckily, the recurrences would be locally at about 90%, and the results after, it's like having the recurrence, we can still perform the planned, hopefully sphincter saving procedure for those patients as well.
Thank you. This one is, I have seen Rita appear on the screen, so I'm just curious. Curious with this kind of TNT, is there any kind of onco nurse to be done or caution or watch more extra compared with the other kind of treatment?
You're asking, are there certain patients that I would follow more closely with the total neoadjuvant watch and wait patients? Definitely. I think the people that have what we would call barriers to care, maybe they live outside of the city in a rural area, and it's hard for them to come back to OHSU for their surveillance imaging scopes. I would watch them more carefully and work harder to connect them with lodging while they're at OHSU. There's also people who just verbalize being tired with getting treatment. Like the surgeons have said before, they have just expressed reluctance in wanting any more treatment done after they've gone through all of the radiation and all of the chemo. And then they are so happy that they find out they don't have to have surgery. And then they find out they are not done yet. Those patients are the hardest to keep track of because they're just tired. Does that answer your question?
Yes, thank you. So because we have the nurse attendees in this video conference, so I think that there should be some question for them, for their side as well. Yeah. Nurse team คะใครมีคำถามไหมคะเกี่ยวกับการดูแลคนไข้กลุ่มโรคเนี้ย Okay. So anyway, there is no more question. So Dr. Fang, thank you very much, and Britta and Dr. Kim as well for answering very clear question. I think we can say goodbye and see you again in July.
Thank you very much, Dr. Liana, for dialing in where you are. Dr. Fang, thank you so much for a wonderful presentation. And Dr. Liu. Dr. Art, it is great to see you again. Swadee ka. And to thank BDMS team for joining. It's great to see all of these hospitals, and we look forward to our next call. Thank you so much. Khap kun ka. Pop kun mai.
สวัสดีค
Thank
รับ
you.
Thank you.
Very much.
Thanks,
Leah,
Leah.
can you
Thanks,
stay
Leah.
put for a few?
I can. Okay. Thank you.
Leah, are you coming to Thailand?
I am. So I will be there with our Dean of Medicine in
Wonderful.
October. So
Right.
he is on the board of, he's on the research board for CIRAT. And
Okay.
so we will be there. And then we will also be up at Mae Faluang University because we do some philanthropic work there as well. So will we get a chance to see you, Dr. Art? Where are you these days?
Phuket.
You're still in
Mostly.
Phuket?
Yeah,
Okay.
but sometimes in Bangkok as well. Let me know. We find some time to meet up. Okay.
We would absolutely love to see you. We'll send you our dates, and maybe either we can come to Phuket and see you, or maybe you could come to Bangkok and see us.
All right. Thanks a lot.
See you.
Nice seeing
Thank
you.
you. Dr. Wanapa, do you want me to stay or call you back?
Can stay. We have a few questions about the trip. Thank you.
Okay, sounds good. I'll wait. Thank you, everybody.
Thank you, everyone. Thank
Bye.
you, Prof. Liana.
Thank you.
Okay, Liana, not Liana, Leah. Right now.
I'm not as important as Liana.
Okay. Anyway, you are important for us. Okay.
Okay, thanks.
Right now, we have a few pending issues regarding with the trip. Okay.
Okay.
For BMT and neuro. Okay.
Okay.
I think Justin mentioned about neuro will be get back this week, but for BMT, because BMT is going to be the first group coming to us in last week of September.
Okay.
So we are hoping to settle that one as the priority.
Okay.
Right now, what we haven't heard back is about the nurse who would be coming with the lead pediatric and the adult bone marrow guys. Okay, so we hope to have the trip confirmed soon. So that's number one.
Okay.
Yeah.
Got it.
And the second one that I just want to tell you is that by June 15, we are trying to confirm back all the project continuation in 2024 by June 15. Okay.
Okay.
If there is a lateness, we're gonna be like only 1 to 2 days late. Okay. We will not try to make it too longer than that. Okay.
Okay. Yeah. Sounds good.
You still remember, right, that we have to confirm back to you guys by June 15 as a deadline. You still remember,
Yes.
right?
No, we remember, but you are our good friends and long-term colleagues. So, we don't we aren't sticklers for the rules with you guys.
No, but we will try to adhere to the rules anyway, so that we are not too relaxed and then make a big mistake, anything like that. Okay.
Right.
So right now,
you guys have a lot of credit with us. A lot of credit.
Thank you. Thank you. Yeah. So right now, what we are trying to do is we're gathering